So the one symptom that brings these kids to the emergency room is pediatric back pain. It's a very common complaint in children, and it's usually a manifestation of a benign process. Now, back pain in kids is often vague, misleading. It's a nonspecific symptom and often leads to delay in diagnosis. But we need to be suspicious if it's associated with these following symptoms that could indicate more serious pathology. So if we have back pain with no trauma history, or back pain of long duration, if it's associated with motor and sensory symptoms, gait disturbance, bladder symptoms, these are all going to be red flags. And we'll start our imaging typically with screening 2-view plain films. But just keep in mind that if these are negative, that doesn't exclude pathology. And we can divide the spine up into 2 spaces. The extradural space, where we'll be looking at pathology involving vertebrae, discs, and soft tissues. And the imaging that we're going to do primarily for that is going to revolve around CT, scintigraphy, and MRI. And then the other space is the intradural, which includes the cord, the meninges, and we're primarily going to be evaluating with MRI. Now, I am going to be showing some spine diffusion imaging. I don't know how many of you actually do any spine diffusion here. Great, okay. And I'm going to give a shout out to Laura Hayes, who has really advanced this technique for us in the department. So here's an example of a 5-year-old with persistent back pain, and plain film, unremarkable. Oh, there it is. And the MRI, which was done with and without contrast, really nothing is jumping out at you in this case. But when you do the spine diffusion, this marrow is grossly abnormal. This is diffuse, restricted diffusion throughout the marrow. And so we're thinking, is there some sort of an infiltrative process here in a young child? We're going to think about neuroblastoma, and indeed the MIBG scan was markedly abnormal. So if we do a side-to-side with the normal spine, with the infiltrated spine compared to the normal spine, these young kids have so much red marrow that it can be difficult to pick out an abnormality. Now, the normal is a little bit more heterogeneous, but I think you'd agree that even on the T2, it's really tough to make that differential. However, the spine diffusion really brings it home, and there's really no question here. And these were done with the same technique. We do them both with a B-value of 500 in the same scanner. See how the cord is the same. The marrow is markedly different in its diffusion characteristics. The ADC is not often very helpful when trying to pick out diffusion abnormalities. So now I'm going to delve into that intradural compartment, and I'm going to talk about spinal cord T2 signal abnormality, or myelopathy. So myelopathy is any nonspecific functional disturbance or pathological change in the spinal cord. And if we suspect a myelopathy, then urgent MR is going to be indicated. And we can separate myelopathy out into compressive and non-compressive causes. So with the compressive myelopathies, the etiology is going to be readily apparent. And I've just included here some examples of what we might run into in kids with compressive myelopathy. This is a child with plexiform neurofibromas. You can see how deformed that cord is and the abnormal signal. Os adenoideum is something that we can encounter with this instability and the myelomalacia, achondroplasia, small skull base, narrow foramen magnum, again, the myelomalacia, and in Down syndrome with the ligamentous laxity. Now, according to the rate of the compression will dictate what the symptoms are usually. So in these slow compressive myelopathies, actually a lot of these kids are walkie-talkie, and they come in and you get an MRI like this and you're like, wow, this child should be totally spastic, and they're not. versus if you have a rapid onset compressive myelopathy. And here's an example of a child that came to us recently, a 14-year-old that had 10 days of unrelenting back pain. And this kid went to every emergency room in North Georgia and was sent home on pain medication. Finally was unable to urinate and came to our hospital, and we did the MRI, and you can see that there is a mass in the thoracic spine, enhancing, narrowing that canal, compressing the cord, increased signal in the cord. So to further characterize that, sorry about that, we did a diffusion sequence, and what you can see is this diffusion restriction throughout this mass, and so we're thinking about something very cellular, something high grade, and this turned out to be a PNET. So now I'm going to go into the non-compressive myelopathies and these non-specific T2 cord signal hyperintensities. And the more commonly encountered pediatric etiologies for these signal abnormalities are going to be ADEM, multiple sclerosis, NMO, spinal cord ischemia, and idiopathic transverse myelitis. And I didn't put viral myelitis in here because, you know, they should have toxic symptoms, signs of infection, so you may be more clued into that diagnosis. So I've made this little chart, and I've written some discriminators that we can look at in an attempt to try to differentiate these different entities. And there are no hard and fast rules, and every case certainly does not fit into a nice little box. But at least it offers just a guideline. So I'll start off with ADEM, which is an immune-mediated disease that results in inflammatory lesions of the brain and spine. So looking at this chart, it's a disease of younger children versus the other pathologies. And then, you know, the other imaging features are not going to be that useful, but the other features could be helpful. It's a monophasic illness. Usually it's going to be post-infectious. They often will present with a rapid onset of encephalopathy, and we're going to look at other findings in the brain that can hopefully lead us to the diagnosis. So what we tend to see is this long segment of T2 signal abnormality. There's my arrow. And confirmed gray-white matter involvement here on the axial. In the brain, though, we see these areas of gray matter involvement on this double IR sequence, which is helpful in identifying pathology in the gray matter. And on the FLAIR, we see areas of white matter involvement. So this gray and white matter involvement, very typical for ADEM. Next, multiple sclerosis. This is an autoimmune-mediated demyelinating disorder of unclear etiology, and you can have isolated cord involvement in up to 20% of cases, which can be really difficult. So here, actually, the extent of the signal abnormality is going to be helpful. These are typically going to be shorter segments. Now, again, this is not 100%, but most often they're going to be shorter lesions. Very often they are not associated with swelling, and they tend to have a relapsing, remitting character with lesions that are separated in time and space. We're going to have positive oligoclonal bands in about 80% of the cases, so that's going to be helpful. And we're going to look at the brain again. So here we have a signal abnormality in the cord, hard to see on the sagittal, but certainly present on the axial. And then when you look in the brain, you can see these classic perivenular plaques that occur perpendicular to the corpus callosum, which are the Dawson fingers that we all know. So in combination, you know, we can feel more confident in making the diagnosis of multiple sclerosis. Now, neuromyelitis optica, which is previously called Devick's disease, has been talked about a lot in the past 5 years or so, and this is a demyelinating disorder that actually follows the demographics of multiple sclerosis. Its timely differentiation, however, from MS is going to be important because the treatment for these two is very different, and treating for MS could actually be detrimental if the child does have NMO. So looking at the discriminators, the affected areas in the brain and in the spine are going to be along these aquaporin 4 channels. And what these are channels that regulate the homeostasis of water in the parenchyma. And the body can develop these autoantibodies to these channels, and so you'll see the signal abnormalities in a characteristic distribution, which I'll show you. The NMO is a multiphasic disease. It is often characterized by bulbar visual symptoms, and so we need to look at the brain in orbits. So this is what we might see. This is a sagittal T1. Now granted, NMO is usually going to be a long segment, but you know, they can be short segment, like in this case here. But what's interesting is that they tend to stop or extend up to the level of the obex. And they can have some enhancement. And the location here is really what causes these children to present with bulbar symptoms of hiccups, nausea, and vomiting. So that's going to be a real telling clinical presentation. Also, we have involvement of around the third ventricle and the hypothalamic region, so just where all these aquaporin channels live. Also, we want to look at the orbits. You may not have clinical evidence of an optic neuritis, but that doesn't exclude it because it could be retrobulbar. So you actually have to do dedicated orbital imaging to see this optic neuritis. Now, in classic DEVIX, we'd make that diagnosis when we saw the presence of myelitis and optic neuritis. However, in neuromyelitis optica spectrum, the presence of optic neuritis and myelitis, they may not be concurrent. They could actually be separated even by decades. So we just need to keep that in mind. Spinal cord ischemia. So hyperacute neurologic signs should suggest that we could perhaps be dealing with a cord infarct, but in children that, again, is not always going to be the case. So looking at these discriminators, the part of the cord that's usually going to be affected is going to be the anterior 2/3 or in the anterior spinal artery distribution. Now, the diffusion imaging in this case could be helpful because we should have early diffusion restriction, just the way we do in the brain. And then if you image in delayed fashion, you should see enhancement due to breakdown of the blood-brain barrier, just the way you would see a subacute infarct in the brain. And so if we're suspicious of spinal cord ischemia, we need to actually look for the etiology. It could be systemic due to a drop of blood pressure, or it could be focal. And I'll show you an example. So this is an 11-year-old with acute, for a child, 24 hours, onset of bilateral hand and leg weakness. And what we're looking for is this classic snake eyes configuration of the signal abnormality. So this is involvement of the anterior horn cells of the central gray. And on the sagittal, we get this pencil-like signal abnormality. And then on the diffusion imaging, we have the area of diffusion restriction. So more than 50% of these kids with spinal cord ischemia don't have an identifiable cause, but we've started to hear more and more about this entity of fibrocartilaginous embolism, and it was first described actually in animals, I think in dogs, but it occurs in kids, and it may be a significant etiological factor. And so what happens is that fragments of the annulus, of the nucleus pulposus, will find their way through a ruptured annulus into the vasculature in the anterior spinal artery distribution and result in a cord infarct. So if you're thinking that a child could have a cord infarct, look at the discs, because if you have these annular tears, that potentially could be the etiology for the ischemia. So transverse myelitis. This is an acute inflammatory process that involves the cord, and it's really a garbage bag term, and it can be disease associated, any of the things that I just spoke about, or in kids, it can actually be idiopathic, and that's the case in 89% of pediatric cases. So believe it or not, there is a transverse myelitis consortium group that has come up with criteria to make the diagnosis of idiopathic transverse myelitis. So the inclusion criteria have to have bilateral sensory motor symptoms. And I just want to make a note here, this I find very confusing. Transverse myelitis, you think that the signal abnormality actually is transverse. Well, the transverse doesn't refer to the anatomic cord signal abnormality. It has to do with the distribution of the symptoms being bilateral. The exclusion criteria is that we can't have an identifiable etiological factor, and we also must have evidence of cord inflammation in the form of enhancement, CSF pleocytosis, or elevated CSF IgG. So basically, it can be anything, and we need to look at the inclusion and exclusion criteria to make the diagnosis of transverse myelitis. So I'm just going to show this case because it caused a bit of consternation in our hospital. And this actually was given three different diagnoses by three different pediatric neuroradiologists that are sitting here today, including myself. So we have a circumscribed signal abnormality. It's in the back part of the cord, so that's not great for ischemia. It's a short segment, so we're thinking about, okay, could this be MS? But the CSF was negative for oligoclonal bands. Could this be NMO? Nothing came up positive. We have diffusion restriction, so we're thinking, oh, again, we're going towards ischemia. Oh, maybe it's cellular tumor, consider that. I really think that we're going to run into a lot of these kinds of cases that we just don't know what to call. And they may eventually declare themselves, and they may not. This child is actually getting better despite all our imaging. So some take-home points are that a timely diagnosis is going to allow appropriate treatment if we can do that. If the initial spine imaging is negative in a symptomatic patient, we should try to repeat that MR in 24 to 48 hours. Interpret the diffusion imaging with caution, especially when you're dealing with demyelination. Always evaluate the total spine, screen the brain in orbits, and interpret the imaging always in clinical context. So now I'm going to jump ahead to pediatric spine trauma, and a lot of this was actually covered in Michelle's wonderful presentation, so I hope it's not going to be too redundant. So cervical spine injury in young children can occur because they're vulnerable to this injury because of their immature anatomy. The fulcrum for injury in older kids is going to be lower in the spine. It's at C5-6. In young kids, it's going to be higher up at the approximate C2-3 level. And what we tend to see in these young kids is posterior ligamentous complex injury without fracture. So the posterior ligamentous complex is comprised of the atlanto-occipital ligament, the atlantoaxial ligament, and the nuchal ligament, and that's where we're going to be looking for trauma. So the imaging typically starts with 2-view plain films with a targeted CT if necessary, if we're thinking there's a fracture present. Now the MRI is going to be really the modality that's going to reveal the soft tissue injury and the cord injury, and if we can see hematomyelia or cord disruption, that would indicate a permanent injury for us. So this is an example of an older child, a 14-year-old cheerleader with neck pain after a fall. And on the plain film, you can see this subtle narrowing of C6-7 and maybe a little bit of subluxation. On the CT, the injury is a little bit more obvious. We have some fragmentation here, but really the MRI is like, wow, look at that. That disc is extruded, extending anteriorly, posteriorly, and it's touching the cord, no cord signal abnormality. Now, in younger kids. And this case was given to me by Maura Ryan from Lurie Children's Hospital, and I think it's just a fantastic example of what can occur in young children. This is a 22-month-old with a history of motor vehicle accident 2 weeks earlier, went to the emergency room and was discharged and had an undiagnosed cervical spine injury. So basically for 2 weeks was toddling around, and finally developed symptoms, and the CT demonstrates this fracture through the dens. Now, if there's going to be a fracture of a cervical vertebra, the one that's going to be most commonly affected is going to be C2. And the weakest point of C2 is that odontoid synchondrosis. And what this really represents is a Salter type 1 fracture that's displaced. So when you look at the MR, you can see the disruption of that posterior ligamentous complex, the edema and that synchondrosis, prevertebral soft tissue swelling, the narrowed canal, and abnormal cord signal. So we need to be cautious and really think hard about performing MRI in these young kids that have cervical spine trauma. So this naturally segs into non-accidental trauma, which is the most common etiology for cervical spine injury in these young kids. So as Michelle mentioned, plain films and CT are not going to be sufficient in excluding injury. And we need to think about MRI. And if we're doing MRI of the brain, then we should be doing MRI of the cervical spine as well. And when we started doing these cervical spine MRIs, our neurosurgeons gave us a little bit of pushback because they're like, well, what are we going to do, when you show us an injury? And so a lot of times what we're showing with MRI may not be clinically significant, but it is of great medical legal significance because we can say this is a severe soft tissue injury here that didn't occur from this child falling off of a couch. So just one word about Skywara again. Actually Skywara was based on plain film and CT findings. So the definition of Skywara did not include MRI. And it really now is becoming obsolete because we almost always or frequently will see abnormalities on the MRI scan in the soft tissues or in the marrow. But this is a case, I think, of true Skywara. It's a 20-month-old that had a temper tantrum and hit the back of her head on the wall and presented to the ED with acute quadriparesis. And the plain film and the CT are totally negative. And the MRI, really, there's no sign of any soft tissue injury or bone injury, but the cord is markedly abnormal. So now I'm going to finish up with pediatric spine tumors, but I'm only going to do the intramedullary tumors. Thankfully, these are rare. They constitute only about 5 to 6% of CNS tumors, and unfortunately, they're most common in young people in the first 2 decades of life. Fortunately, they're usually low grade, but unfortunately, they're in a place that has high morbidity and mortality in the cord. Most of the tumors are going to be of glial origin, 90 to 95% of them, with the vast majority being astrocytomas. And of those astrocytomas, 75% of those are going to be JPAs. The next biggest group in children are going to be the gangliogliomas, and the ependymomas are actually rare and occur typically just in the setting of neurofibromatosis type 2. So MRI is often not effective in determining tumor pathology and tumor extent. So here I have 2 examples of tumors on very different ends of the tumor grade spectrum. We have a low-grade tumor, a JPA, a high-grade tumor, a GBM. If you look at the post-contrast T1, they almost look identical. On the T2 images, you can see the signal abnormality that's extending along the cord, both in the JPA, in the GBM. What's edema, what's tumor infiltration? It's really hard to tell with MRI. So the treatment goal for these tumors is going to be a gross total resection while preserving neural function. And I think this treatment goal is really going to define what our imaging goals should be. And so the primary imaging goals are going to be to detect the presence and the extent of tumor, and if we find the tumor, to try to determine the tumor grade. And a secondary goal is actually to establish a pathologic diagnosis, because we're just not very good at being pathologists, and more often than not, biopsies is going to be performed. But we can at least try to differentiate these tumors by looking at different things. We can look at the location of where they're occurring, their signal characteristics, the presence of bony remodeling, and diffusion characteristics. So here's an example of a tumor that's occurring in the thoracic region, and one that's occurring in the region of the filum terminale. Their signal characteristics are exactly the same. They both enhance, but just by virtue of the location of this mass here, it's a myxopapillary ependymoma. Next, we can look at signal characteristics to try to give us a clue as to what's occurring. We have two tumors that are both occurring in the cervical cord. This one is very bland. This one is very heterogeneous, and that's a finding that we can see with ependymomas, because they tend to be hemorrhagic. They tend to be more heterogeneous in appearance. Bony remodeling can give us a clue as to the grade of the tumor. So if you have a low-grade tumor that's been sitting around for a long time, you may eventually get vertebral scalloping, and this is a really advanced example of vertebral scalloping. And I think this child, we followed it for over 6 years and finally developed intracranial metastases, versus this GBM, which grows so fast there's really no time for any scalloping, and within 6 months had developed intracranial metastases. So diffusion imaging now, and we're just starting off with this, may be helpful in differentiating tumor grades. So this is an example of a ganglioglioma that we've been following probably for 13 years, and had been stable, but then started to grow very slowly, millimeters at a time. And then the more rostral aspect of this tumor started to grow a little bit more rapidly. And, we ran a diffusion sequence, and there was diffusion restriction in there. So we're concerned that perhaps this had de-differentiated into a higher grade tumor. 4 months later, this is how rapidly this tumor expanded. And on biopsy, this was a grade 4 anaplastic ganglioglioma now. But I think where the diffusion has really helped us a lot is in the detection of drop metastases. So drop metastases are actually the most common extramedullary intradural tumor in children. And routine MRI and lumbar puncture have really high false negative rates for early detection. And we don't want to get to this degree to make the diagnosis of drop metastases. We want to try to make that diagnosis as early as possible to improve the survival for these children. So this is an example, and some of you may have seen this. We did publish this. And this is a case that really convinced our oncologists to embrace spine diffusion. It's an 8-year-old with treated ATRT that was undergoing surveillance MRI. And the T1 and T2 weighted imaging, stone cold normal. When we ran the diffusion imaging, and there was this little nodule of diffusion restriction, we're like, could that be a cellular drop metastases? Because the tumor in the posterior fossa originally was highly restricted diffusion. And nobody really, they were like, okay, is it not? Well, they became a little alarmed, and so we did a short interval follow-up in 2 months. And the imaging still, it doesn't jump out at you. The post-contrast, totally unremarkable. On the post-contrast, maybe we have a little signal abnormality here, but there's no question about the findings on the diffusion imaging. That nodule has significantly increased in size And now we have a second one at the ventral aspect of the cord. 4 months later, this is what we saw: extensive leptomeningeal metastases. Interestingly, even with this amount of disease, it's not like the enhancement is out there. And that's not unusual in these really high-grade tumors, and they tend to be so necrotic that they don't show a lot of enhancement, which is probably why it's hard for us to pick them out just on routine imaging. So some take-home points are, when you're dealing with spinal cord tumors, look for differentiating imaging features. Think about surveilling the brain, even though it's a spinal cord tumor, because you could have disease intracranially, and restricted diffusion can assist with tumor detection and tumor grading. And in conclusion, symptoms of acquired spine pathology are often going to be nonspecific in kids, and we need to look at the history, the clinical examination, and the laboratory findings, which are all going to be critical for diagnosis, and knowing when, where, and how to image these kids can reveal the answer. Thank you.